Okay, so today we are very fortunate to have Mary Blankson. She is APRN and is the Chief Nursing Officer for Community Health Center, Inc. She oversees the diverse nursing services across the CHC network, including primary care, healthcare for the homeless, and school-based health center services. As CNO, she ensures the quality and expansion of nursing services, the development of nursing policy, and continuing nurse education. Mary also works collaboratively to ensure joint commission and also patient-centered medical home compliance throughout the CHC. Building upon her service in various mission organizations, Mary continued to develop her passion for meeting the needs of the underserved, earning her MSN at Yale University in 2005. Mary joined Community Health Center, Inc. As a family nurse practitioner shortly after graduation. While at CHC, Mary has served as the on-site medical director of New London County sites and the vice president of the medical staff and the chair of the Pharmacy and Therapeutics Committee, and has served as a preceptor for CHC Nurse Practitioner Residency Program. She has earned a DNP at Johns Hopkins University. Mary is certified and holds professional membership in the American Association of Nurse Practitioners. While at New London as a primary care provider, Mary was the New London County Project ECHO HIV and HCV representative. Her passion to support the management of hepatitis C within the primary care setting is what promoted her to choose the DNP capstone entitled Increasing Identification and Treatment Referral of Individuals with Hep C in the Primary Care Setting through clinical dashboards. She continues to support various other quality improvement projects throughout the agency to really increase the visibility of nursing's contribution to the medical home. So I'm going to turn it over to Ms. Blankson. Thank you for being with us today.
Thank you so much, Lisa, and thank you so much to everyone for joining us. Apologies for such a long bio. I think as many of us know, working at a health center means you wear many different hats, but much like many of my colleagues, I've been working at an FQHC for my entire career, which is about 15 years exactly now. Doesn't quite seem possible, but really, really love the communities that I serve and just the creativity and the innovation that I see all the time that FQHCs are able to bring to the table across the country, as we really are the largest health system in the country. So, so nothing is too big or too small for us to better serve our patients. So today's presentation, we're going to talk a little bit about rethinking staff roles and workflow for telehealth services, as I know that every organization across the country has worked very, very hard to make the transition to telehealth because of our COVID-19 pandemic. Okay, hold on. There we go. I have no conflicts of interest to disclose. And really just with this presentation, I want to acknowledge the fact that, many organizations, we're already on the journey to implement or enhance their team-based model of care and their roles prior to COVID-19 and telehealth. This journey is always filled with barriers and facilitators for its success. And obviously telehealth has further complicated team-based care implementation, given that it's fairly new territory for many health centers, particularly in medical. Although I will say that many health centers do have experience in implementing telehealth on a limited basis, typically in behavioral health. So certainly leveraging any knowledge that you have in telehealth is going to be very important, but it really was a big lift for everyone across the country to be able to operationalize their medical departments in particular to go live with telehealth. So our objectives for today, we're going to understand the development of the patient-centered medical home movement as a key driver for team-based care and to support the development of team roles. We're going to describe team-based care, including descriptions of key roles on the primary care team, including a discussion of key changes due to telehealth care delivery. We'll talk a little bit about integration as well, thinking about the multiple disciplines that are typically present at our health centers and how we work together and how that looks very, very different in a telehealth world. We're going to use examples from Community Health Center, Inc., just as case examples. But again, much of the thinking you'll be able to apply whether you're a small health center or a larger health center, whether you are significantly more rural or whether you have some urban centers as well. And then we're going to identify barriers to the full realization of telehealth. You may know who we are, but I come from Community Health Center, Inc. We're a statewide federally qualified health center in the state of Connecticut. So each one of those blue dots is where we have a large brick and mortar primary care hub. So we have 16 of those across the state. But we do deliver care in 204 sites, although the majority of which are currently closed down because they are school-based health centers or mobile dental locations. Really just our primary hubs are open. Right now, our healthcare for the homeless sites, we're doing limited days there, but really maximizing on testing there. Most of our homeless populations have been moved into hotels and are still in those types of living situations right now. We have a fully integrated model with dental, behavioral health, medical, and then other ancillary care services, which I'll talk about in a while. And you'll notice in the lower right of your screen are 3 foundational pillars: clinical excellence, which of course, even in our telehealth care delivery, we wanted to figure out how do we not just deliver and respond to the patient's need, putting out the fires, but also how do we make sure that we can continue the model of quality care that we subscribe to, which involves panel management and planned care for the patient, and really can address all of those things even in our telehealth world. We do focus a lot on research and development, so I will talk throughout the presentation about ways that you could measure the implementations that you're doing to make sure that you are achieving incremental success. Or as we did a rapid rollout and then sort of refined from there. And then lastly, training the next generation. We are thinking about what is going to happen come September, when our students, our medical students or nurse practitioner students are back in school, are looking for clinical rotations. What does that even look like? Are we going to be able to provide those opportunities for students? We also have a medical residency that participates in one of our locations. So there are some significant challenges with regard to thinking about our on-site footprint, like how many people are we really going to allow in our buildings and in our space? This is just a little bit more about us. So we focus on these areas. We do have an urgent care line as well, and a center for key populations. This is just our Weitzman Institute. So we do have a Weitzman Institute for Research and Innovation, and we do have offices in California and Colorado, as well as Connecticut. And we deliver a fair amount of different varieties of services. I want to certainly draw your attention to the green dot, the clinical workforce development in our national cooperative agreement. There are many resources available on our websites, different webinars and talks, or even templates for standing orders and other things through our clinical workforce development national cooperative agreement that we have with HRSA. We will be continuing that, so there'll be some upcoming stuff with regard to team-based care and specifically advancing your models of primary care registered nursing roles. So if that's something that interests you, you should check that out. And all of that is freely available and paid for by HRSA for all FQHCs across the country. So as we think about kind of team-based care in the context of telehealth, I think it's important for us just to really put it in the context of the patient-centered medical home model. I think, if you have achieved PCMH recognition, really great job. And those of you who are still on the journey kind of working towards that, don't give up. It is a lot of work to put the structures and the policies and procedures in place. But really, once you've built it, you will see those fruits of your labor in terms of the processes that you put in place, and you'll really see that your patients are supported and scaffolded in the way that they need to be. So PCMH, really the concept came out about in the 60s, really focused on pediatric care. The AAP talked about it with regard to children and youth with special healthcare needs. And then obviously in a modern day standpoint, we have the AAHC, the Joint Commission, and NCQA, the National Committee for Quality Assurance, that all provide recognition for primary care centers across the country who want to apply to have this sort of recognized title or recognition. I will just use NCQA's concepts because I do think that they are the most kind of well developed, and really the Joint Commission and AAAHC, they're very, very similar. But again, this is recognized as a symbol of quality. It helps you to develop your quality standards and performance measures, and helps you to sort of track your quality and continue that incremental improvement over time. NCQA builds their model on concepts that then have competencies and criteria underneath them that a health center must meet in order to be able to sort of be recognized. So I just wanted to bring the 6 concepts that sort of are under NCQA. So team-based care and practice organization, knowing and managing your patients, patient-centered access and continuity, care management and support, care coordination and care transitions, and lastly, performance measurement and quality improvement. And I think these concepts are really important to keep in mind. And really the first 3 we're going to be talking about today. I will be coming back for another hour a little bit later on to focus more on care coordination and care management. So I'll sort of bring it back to kind of the latter half in the next hour that I'll be spending with you all. But I do think it's important because as we think about what the patient-centered medical home model is supporting us to do, we need to rethink how we do those things within the boundaries of walls. We do also, at CHC, we really use Tom Bodenheimer's 10 building blocks for high-performing primary care teams, really, again, as just something that helps to guide our thinking as we've developed our telehealth model. So I did just put that in here so that you guys will have that for your access. And then lastly, we tend to think about components of integration. And I think, this pyramid we've actually presented like dozens of times. And what's interesting about this is that the second layer of that pyramid, facilities and systems, have completely changed since COVID-19. So, it was very, very interesting. We were putting together a manual kind of on team-based care, and we had to just stop because we were having so many disagreements about what does team-based care look like now that we're doing it via telehealth. And did we really, what were there things that we didn't understand about team-based care that now that we're in a teleworld, now we can explore and think about with regard to the care of our patients? So I do think one sort of special sauce to our success is that we do have 4 clinical chief positions. So there's a chief of medicine, a chief of nursing, a chief of behavioral health, and a chief dental officer. And the 4 of us actually really work as, we tend to, these days, to call ourselves comrades at arms, but we are on a level playing field with each other. We don't really do anything without the others. We want to make sure that our teams work together. Vina, our chief medical officer, can't do anything without me because it's typically the team that's supporting her, and I oversee all of our medical assistants and our nurses across the network. And I can't really do anything without her either because I need provider buy-in. So this kind of integrated or interdisciplinary leadership model is helpful, particularly in an environment of change. You need leaders that each group of staff can look to be sort of the visionary or the one who can just sort of listen to them and bring their thoughts and their ideas to the larger leadership team table. So that's really important. So I think as you think about sort of telehealth and look back maybe on the last 3 months or 4 months now, think about how your leadership team is structured and how successful the leadership team has been, and what are some of the challenges that you've had as a leadership team as you've been figuring out and deciding the way that you're going to go. Are there groups of team members that maybe were not well represented at the table because they didn't actually have a leader that was sort of assigned to or really prioritizing their perspective? So I think that's just a reflection point that I want to support sort of every health center to do as you're thinking about and reflecting on your last few months. So, and all of you have probably seen a similar version of this picture, right? So the latest thing in the last decade or so has been moving towards interdisciplinary pods to promote team-based care, where co-location was the hallmark of what brought us all together. But of course, telehealth has completely messed that up, right? So no longer, if we look back at this pod picture, nobody, like there's at least, the people on the left and the people on the right, they're not quite 6 feet apart, like probably in the back left corner, maybe she would make it. None of them have masks on. I'm not even seeing where the bottles of Purell are on their desks or anything like that. So this would worry me in a COVID-19 environment, right? So we know that the pods of the past are not going to be that of the future, at least until we have a safe and effective vaccine. And I think the other challenge, of course, is that we know that telehealth is here to stay. Some patients have absolutely embraced telehealth, really enjoy telehealth. They don't want to come and sit in our waiting room for 40 minutes while they're waiting to get into an exam room to see their provider. They'd really much rather be at home or doing what they want to be doing, and then right when it's time for the appointment, to log in and say, okay, I'm ready and you're ready. So my appointment time is much less. So I don't see that these things are going to go anywhere anytime soon. So the good news is we made a rapid transition, and now we have the opportunity to fine tune our implementations right now. Probably, I'm guessing, over the course of the next year, as again, we hopefully will have a vaccine available at some point. Okay. So first, as CHC kind of thought about telehealth implementation, I think the first thing that we always naturally do, and this may be something that you as a health center sort of want to do, is we reflected back on our process and thought about doing a SWOT analysis. So for those of you who may not be familiar, a SWOT analysis is just strengths, weaknesses, opportunities, and threats. And it gives you that opportunity to really kind of lay everything out on the table so that you can make effective decisions moving forward. So as we thought about our telehealth conversion, of course, we did have some strengths that we brought to the table. We had engaged and involved leadership and strong IT teams and business intelligence teams that could help us to set up a system. Our staff were very mission oriented, so to have the drive to be able to meet the needs of our patients, even in the midst of a pandemic, was very important, and we wanted to leverage that. We have an improvement oriented culture, right? Our teams were constantly supporting them to know that change is going to continue in primary care. And we used to tell them this even before the pandemic. Change is coming. Primary care is changing all the time because of value-based, because of so many different things. So our teams are already used to quality improvement. They're already used to things changing all the time. And so leveraging that. And then, of course, at our organization, we did have some existing infrastructure. So our teams were working off of laptops. So we had the ability to deploy people to work remotely. We had the ability to put people in separate rooms because we weren't boundaried by the fact that, people were working on desktops. Systems that were really struggling, early on, oftentimes were ones that were working on desktops where they had to, radically pick up and move workstations to various different places in order to make sure that staff were physically distant, et cetera. Certainly, it's no surprise that we had many weaknesses as well. So no existing telehealth platform. We actually were doing zero telehealth in medical. We were doing a little bit of telehealth in behavioral health, but that was it. And obviously, like many of you, we were existing in a fee-for-service model. We had some value-based contracts, but most of our work was fee-for-service. So again, to go into a pandemic where we went from a system where, we lost about 60% of our in-person visits at first, we knew we had to rapidly pull out telehealth. And when we did that, we were able to actually very quickly bring our visit counts up to today. Even now in July, we're actually meeting our budgeted visit expectations through telehealth. But that has certainly not been without sort of an all hands on deck approach. I'm not going to go over opportunities and threats kind of in detail, but I will say that as a part of our story, certainly a heavy amount of advocacy, lots of phone calls to the state, lots of phone calls to our representatives, lots of phone calls to Medicaid and other offices to continue to advocate for where their regulations were not clear, where we felt like they didn't give us the latitude that we needed, even to the point of negotiating a rate for testing. So our state actually does pay us per test that we do through their high volume testing, again, because it's our staff's time and energy. We're returning all the phone calls, we're filling out all the DPH reports. All of that time is in fact money. So again, really be thinking about who are the people in your center who have been your advocates, who have been the ones who have been raising Cain at the state, so to speak, and continue to have them do so, because we are going to continue to need advocacy as things continue to go on. Okay, Then we sort of looked at existing foundations. So again, the culture and values of the organization that really promoted telehealth. So an organizational culture of healthcare being a right for all. So we knew that we were still going to have to deliver some in-person care because not everybody was going to have access to telehealth. Not everybody has a smartphone, not everybody has internet at their house. And that there's an expectation of excellence, right? So again, our staff knew that, we will start and do a rapid rollout, but we will continue to refine things over time. And then of course, staff being flexible. And I think this has been super important during COVID-19. I feel like every person I interview, even during this pandemic, I'm saying, I want to put something in their job description that says must be like Gumby, very flexible, must, be able to change, switch gears quickly, et cetera. And then of course, just our values for national and statewide presence. We have many partners across the country, so we were able to do some collective learning. Nothing will help you more. And again, just huge thank you to the Arkansas PCA. Like, what a great way to sort of bring health centers together from across the state to be able to hear what are the struggles that folks are having, what are the different solutions, identifying best practices, and sharing ideas is extremely, extremely important in the success of this rollout. We did also have, as I said before, existing technology and even some policies. We had a remote worker policy that helped us to be able to get some of our workers at home and out of our physical plant sites so that we would actually have space for the people that were going to stay there. And then, of course, some centralization in terms of policies and procedures, our infection control committee that supported a lot of this, our centralized support systems that we've actually switched gears, who before some of them were supporting mainly eligibility, but now are doing telehealth concierge, as we like to call it. So patients who have not had a video visit or a telephone visit for the very first time can have a quick appointment with someone to explain the process and to kind of go through and vet what they have access to for technology to make sure that they can be successful in their visit. Oops. So when we think about our rapid implementation, so of course, as I said before, the regulatory advocacy, we mobilized current staff and patients to let them know telehealth's coming, so be prepared for it. We did some texting campaigns. We put things up on our social media, put them in various different places, as of course our communities are very diverse and people look in different places to find this information. Then we actually did a fair amount of redeployment of staff, which I'll talk about in a moment, but then look to how can we make sure that we continue care. In a telehealth world, it's very easy to say, well, the provider could be a provider from this site, but the patient could be a patient from this site. But again, making sure that patients did have a familiar face or a familiar voice and a familiar process, I think was very, very important, particularly those that were mistrustful of telehealth at the beginning. So to have the rooming process look similar, to have their typical medical assistant or a staff member that roomed them, that was really important. To be able to see their PCP or talk to their PCP on the phone with a telephonic appointment, that was really important to them. And then, of course, internal and external communications. And we'll talk about communication a fair bit because honestly, even in our what I would tend to feel like is over communication, I feel like many of our staff members felt like it still wasn't even enough communication. So redeployment of staff, we redeployed all of these groups. So our school-based health center APRNs actually started doing telehealth visits for COVID. So any patient that called in that had questions or concerns about COVID, we trained this team to really become the experts on COVID and doing COVID triage and giving all the patient education and other things. And just a lot of reassurance for our patients. They were very, very scared at first. We created a templated visit to support them. So those nurse practitioners would go through that full template, do the data collection, determine the risk, and then support the patient if they needed testing, coordinate the care, make sure that they got to go where they needed to go, or whatever other services that they needed, and they would deliver that as a telehealth visit. So even though our nurse practitioners weren't still seeing patients in the school system, they were able to still see billable telehealth visits and do that specifically for all of the COVID calls coming in. Our school-based health center medical assistants, instead of working in our clinical areas now, started to work with our operations teams in what we called a telehealth a telehealth call team. So just as phone calls from our patients began to decrease, we found the need to really proactively call our patients and say, hey, we know you haven't called us, but we're noticing that you're due for care. Can we go ahead and set you up for a telehealth visit? So those medical assistants were actually having these conversations with patients, talking to them about telehealth, and really supporting them to set up those appointments. And what we found was that with those phone calls, anywhere from about 25% to 40% of those calls actually converted to a telehealth visit. So again, telehealth was not for everybody, but at the very beginning, we didn't really know kind of which staff or which patients really enjoyed telehealth and which ones were maybe less than excited about it. Our school-based health center behavioral health team actually still supported some of their kids who were from the schools, again, doing telehealth behavioral health. But then our school-based health center behavioral health teams also did a fair amount of warm handoffs for the rest of the organization, which I'll talk about in a bit as well. And then our dental teams actually became our testing teams. So our dentists actually are collecting nasopharyngeal swabs, our DAs and hygienists are helping to process the samples, they're also doing registration for patients who are interested in becoming tested. We even utilized or redeployed some of our administrative workers to, again, support phone calls to patients to really proactively make sure that we were filling up our telehealth schedules. Particularly from a training standpoint, if you're going to train people in telehealth, you have to be able to provide for them the volume of telehealth visits for them to be able to practice, particularly if it's video visits where those are much more complicated in terms of, having a good flow between the team member who's rooming the patient or virtually rooming the patient and the provider that's actually seeing the patient. And then we actually rolled out a new intervention called a Summer Fellows, which we invited, folks who were off from the university over the summer, or even like high school graduates who were, off for the summer, to do some virtual project support and program management for us over the summertime to continue to help us refine some of our telehealth implementation. So again, a great opportunity for a student to be able to get an experience working in a health center, but also a huge benefit to us as they are excited, they are energized, and honestly less expensive than most other program managers or other sectors of teams who are formally trained, but really gave us the additional hands and feet that we needed to refine our programs. With our rapid implementation, we had quick and real-time communication, and we also created a special email bin called CHC Virus, and they could write in any questions that they had about COVID or telehealth or anything, and we had an entire team of executive leaders that were a part of that, and we each sort of divided and conquered to make sure that our staff would get a same-day response. And that made it very easy, I think, to sort of organize the responses and really keep the pulse on what was happening in the organization. Then, of course, we had a very transparent conversations, typically through our town hall meetings, which were sort of our all staff meetings, to make sure it was very, very clear to everybody what our strategy was going to be in terms of making our change and our shift to telehealth, what our benchmarks were, what we were looking for in terms of budgeted numbers of visits, because our goal was to make sure that we didn't have to lay off or furlough any staff in our organization at all. And so if we were going to do that, we knew what it was going to cost, and we knew what we had to do, not only just obviously to pay the bills, but to make sure that our patients still had access. And then we actually refined our incentives to follow that. So in that first month of telehealth, we actually had 3 weeks of additional incentives for providers to really get them to go from a low number of visits and to get them back up to budgeted visits. Just as an incentive, they, honestly were very incentivized to learn telehealth, to get involved, to be excited about interacting with their patients in this way. And they had that 3-week period of additional incentives to do it, which really helped us to make that rapid implementation that much more successful. Okay, so as we think about our interprofessional team, I think it's important that we think about, of course, we have the patient in the center as part of the PCMH model, but then we have all of our disciplines around it. And certainly what we noticed was that some services we were no longer able to offer during COVID-19. So some of these things, like for example, our dietitians, our CDEs, they could all deliver telehealth and virtual care, but a chiropractor could not. And a chiropractor, it was a longer visit, much more hands-on. We were very, very concerned about this. So we actually discontinued this service for a period of time, and we're actually still discontinued to this point. We still delivered podiatry care, but again, we made sure that the podiatrist had a telehealth encounter with the patient to talk about their issue before, to really determine who needs to be seen in the office and who doesn't. Because our goal was not just to bring in anybody, right? But we needed to make sure that our on-site footprint was as less as possible. Considering sort of the increasing cases, all of the unknowns that we have around asymptomatic carriers, we just really wanted to keep people out of our office as much as possible. And then things like retinopathy screening, we're not even doing right now. Spirometry, of course, I don't want a single person blowing into a spirometry machine. So those services are shut down at this point in time. And going back to our pod design, so we typically would have 2 medical providers, 1 registered nurse, and 2 medical assistants per pod. So each provider would have a medical assistant, and for us, we use a medical assistant to room the patients. You may use an LPN, you might use a nurse, whoever it is, but whoever is sort of doing that rooming process, they tended to be more of a dyad with the provider, whereas the registered nurse for us tended to be much more independent, doing independent standing order nursing visits or delegated order nursing visits, which I'll talk about in a moment. And then we also had a behavioral health clinician that was linked to this. And then our students and trainees and other people within the pod. So certainly with a virtual pod, that looks very different. And the relationship between the provider and the rooming staff member, so for us, it's a medical assistant, became extremely, extremely important. Whereas the relationship maybe between the provider and the nurse was a little bit less important. And certainly pretty much all of our behavioral health care delivery went virtual. We do have some very small crisis intervention groups and a few other things that do have to be done in person due to state regs, but that really like 98% of our behavioral health teams are still doing telehealth and virtual work. Our medical assistants who do the rooming, much of their work is still exactly the same. They're virtually rooming patients, whether it's by telephone or via video, which is, as I said before, a little bit more complicated. We use Zoom as our technology for our telehealth platform, and certainly lots of people use very different things, but typically you are able to kind of recreate the conversation that our patients would have with the rooming staff member, because again, the provider typically for telephonic visits, sometimes there's a time limit that they have to be on the phone in order for it to be a billable visit. Typically for video, there doesn't. But the time of the rooming person doesn't necessarily count in that. But one thing that we know for true is that providers don't necessarily tend to be as good at doing planned care in a way that will give you structured data capture. Providers tend to free text a lot of things, and certainly in the busyness of what really is concerning the patient for that day, it's easy to drop balls and to miss things. So having a rooming staff member be able to organize the planned care, still have those conversations like, hey, I'm going to send you a fit kit in the mail because it's time for colorectal cancer screening for you. So I'm going to explain it to you over the phone. I'm going to send you some materials. I'm going to prep everything for you, but then you're going to receive it in the mail and I want you to mail it back. That's going to be very, very important. Depression screening, screening and brief intervention and referral to treatment, all of these things can continue to be done either telephonically or even via video. There are very few planned care items that you cannot do in a virtual world. Certainly our medical assistants also continue to do panel management. There were times that they would have groups of patients to call who were overdue for services and for care that the provider would want them to schedule and get in their telehealth visit. So when we think about the provider and MA dyads, as I said before, the visit types, we do have some in-person visits. We have telephonic visits and then video visits. In the video visits, both the medical assistant and the provider are in the same video account, but the MA is the one who's sort of choreographing where the patients move. So much like today, you were in a waiting room for Zoom, our patients will sit in a waiting room and then the medical assistant will sort of put them in their own separate breakout room. And then we'll ask what's bringing them there today, if the patient has a home blood pressure monitor or other means to be able to take any of their own vital signs at home, they will go ahead and have the patient do that. They'll document all of that. And then they'll go through whatever items are due for them in their planned care that day. Once they are ready, the medical assistant will then place a message within the electronic health record that says patient is ready. So now the provider knows I can go into any room for these patients who the medical assistant has finished rooming and conduct my visit. Telephone is a little bit easier in the sense that the medical assistant would then call the patient, have the phone conversation, do all of that telephonically. Then they would use an instant messaging system, Link or Skype, to let the provider know that the patient was ready for them. One thing that this really helped, which I think is helpful to know, is when it comes to physical plant space, oftentimes what can limit the number of patients that your providers are seeing oftentimes is exam rooms. So really in a virtual world, exam room space goes away. So it becomes a lot easier for your team that is rooming patients to get a little bit ahead of the provider, so that way the provider doesn't get backed up if, they're waiting for the rooming process to end, or, things like that. And schedule management for efficiency is also important. So many providers, switching gears is very, very complicated. So we want to make sure that, our video visits were lumped together. Telephone and in-person were very easy for providers to flip back and forth, but video was very, very complicated. So we would allocate a portion of the schedule every morning and a portion of the schedule every afternoon to video, to make sure that we could begin to make the transition of patients being comfortable with video, but not in a way that we lost the efficiency for our provider teams. As I said, we also had telehealth templates for our electronic health record to make sure that our providers easily collected the information for the consent, documented time if that was required. So again, look at your state regulations and see what can you actually create a telehealth template for to be able to support your teams to make sure you have appropriate and correct data collection. We also had a face-to-face request process. So if there was a patient that you wanted to bring in, but it wasn't for a reason that was approved for a face-to-face visit, you would have to enter a request, a telephone message that would go to a centralized bin that many of us, the chief medical officer, myself, and a couple of other people would go in and work, and we would review the need for the patient and then determine whether the patient could be scheduled for a face-to-face visit. It's very, very challenging for your on-site teams if 5 people show up at the same time and you have to measure their temperatures and make sure that they have a mask and put them in a separate exam room. And then of course you're cleaning exam rooms in between. So for in-person care, it was really, really important that we tried to require a telehealth visit first, if we could, to make sure that the reason for the in-person, that we absolutely vetted that it was necessary for the patient to come in person. We also had a photo request process. So we've created a process where a patient can actually take a photograph of a rash or whatever it may be and upload it to a secure drive, so that then that can be deposited into the electronic health record from our indexing team or medical records team, so that our providers can actually see a picture of the rash or see a picture of the swollen limb or whatever it is that they're trying to treat via a telehealth manner. Even though you may think with a video visit that you can see things really well and that you're sharing, that you'll be able to sort of at least examine the patient visually, the reality is that normally our video is not good enough to really give us the same level of viewing that a photograph could, particularly on today's cell phones. Like, the cameras are really fabulous and we can get a really, really good look at a rash or a good look at demarcation if somebody has a cellulitis, things like that. So really making sure that we could leverage today's technology with as many patients as possible, even in a virtual world. Then the other thing that can be very complicated is staff and patient location. So whether the patient is at home, calling a staff member who's on site, or whether both of them are at home, maybe you have your providers working remotely from home, and making sure that they're able to get the service that they need to get everybody up and running. And we have a variety of staff that want a variety of different things. We have some staff that live in places where Wi-Fi is not great. So we have built some or sort of reallocated some space specifically for telehealth visits on site. So the provider can come on site, they can have a private room where they can close the door so they can remove their mask, because we do have 100% masking policy at our site. And then actually see the patient, even though the patient is at home, but they have access to our work Wi-Fi. But then we have many staff members who are just working from home. And again, we've given them support and guidance from our IT department to get as many of them up and running as possible. If we're unable to get them up and running, then we do have them come into the site. But it's been fewer and further between. But obviously, the more rural you are, the more challenging that may be. So you may need to think about, how do I create spaces in my location where virtual care can be delivered, whether it's a telehealth pod or whether you repurpose some of your exam rooms to be more office-like, or modifiable to an office so that telehealth could be delivered from there. And then incident to care is very important. You might find that maybe a patient had a telehealth visit with a provider and the provider said, it'd be really helpful if this patient had a rapid strep. So really knowing how you can order incident to care, have the patient maybe spin by the site, have a medical assistant or a nurse come out, collect that throat swab, and then run it back in the lab. Now the patient has left the site, they drove up, basically got swabbed, patient left, and the nurse or MA are now running that swab and giving the result to the provider, who can then contact the patient back and say, okay, based on your symptoms and based on your rapid, data collection, this is what our plan is going to be. So there may be times where the majority of the care is a virtual care, but then there may be a small incident to component. And I think it's very, very important for us to leverage this as much as possible. It takes 7 minutes to run an A1C on site. And so if you were seeing a patient on site for diabetes follow-up, they're going to be on site for 20 to 30 minutes. And the longer they're on site, the higher risk the potential contact is. So if you could do the diabetes intake completely virtually, and then just have them come by, have their finger pricked through the car window, have that result put in the chart within 7 minutes, you could then call the patient and have a long conversation about their diabetes when they are safely at home and you are safely physically distanced from them as well. So again, be very creative about how you think about incident to care. It doesn't mean that the entire visit then needs to be done in person. It could just be that those components are separate. It's 144, or I think 1244 for you guys. So if you do have questions, begin to put those in the chat, because we're going to break in about 4 minutes for Q&A. I did put a few examples in here just of medical assistant planned care. So this is our dashboard. And again, you need to go through all of the planned care items that your staff members use, or maybe that they may order or complete on behalf of the provider, and make sure that those things can still be completed in a virtual world. It may require you to change your workflows a little bit. And again, the more you can do that, it really will help your providers to be more efficient, to really be able to focus on the visit at hand versus all of the planned care and the visit. And you'll notice that your provider notes will be locked more timely, and certainly providers will be much happier because they are not having to remember everything off the top of their head, but you have a dashboard or some other type of support that will help to make sure that what is due for the patient is actually done for the patient. I do want to talk a little bit about domains of nursing practice. So our RNs typically are the ones who are doing our telephonic triage. They also do a small amount of in-person triage, because again, our in-person footprint is much smaller. But the bulk of what they're doing outside of complex care management, which we'll talk about in the next hour that I spend with you guys, they're really focusing on completing their own independent visits. So our nurses actually have their own telehealth accounts where they are completing visits with patients focused either on standing orders or delegated orders. And the difference between those two, a standing order is something that applies to a large population of patients. So for example, we have standing orders for patients with hypertension, or standing orders for patients with diabetes or uncontrolled asthma. We have delegated order sets these are more specific to the patient. So this is a provider order where I, as a provider, would have to say, hey, when you see John Smith, this is what I want you to do for John Smith. And in the state of Connecticut, we do have the ability to bill 99211 in-person visits, and nurses, RNs specifically, can bill telehealth encounters. So it's very important for you to look at your regs, and even if you cannot bill sort of telehealth within your state for your Medicaid population, again, really be looking at your Medicare guidelines, looking at Medicare CCM as a great opportunity for your nurses to connect with patients, do virtual care, either by telephone or even by video, if it would be helpful, collect that data and information, and then input that, as minutes towards that 20 minutes that you can then bill for Medicare CCM. Annual wellness visits is another great example where nurses can do the bulk of the visit, and then the provider can actually drop in at the end to just see the patient for a few minutes, but the nurse has already done all the data collection for that elder population. And I will tell you that for those patients, we've really received a lot of good feedback from them, just, you know, feeling very lonely, feeling very isolated, very scared. And so the connection with our teams has been really valuable. I did just put a couple of slides in here about nursing standing orders. These are some of the examples of more of the acute standing orders that we have at our organization. And as you can imagine, some of these can be translated into a virtual world, but some of them are specifically in-person visits. So again, we really had to balance which standing orders were we going to keep and which ones were we going to modify to make them to be a telehealth standing order. This is just some data and information about the types of visits that our nurses do. So again, if you're thinking about ways to leverage your nurses, particularly as it comes to creating more access for your primary care providers, these might give you some good ideas. And these are the types of diagnoses that they do for chronic illness care, but we'll talk more about this in the complex care management lecture. And then just to talk for a moment about behavioral health integration, our nurses and our other staff are very, very involved with this. And again, before we used to have a reactive and a proactive warm handoff, where reactive would be a patient needs behavioral health in the moment, and then we would access them right within the context of the appointment. And then proactive would be where a behavioral health clinician would actually identify somebody in a medical schedule who was at high risk and then sort of come into the room and introduce themselves. So as you can see, proactive right now, we are not currently doing, we are only doing reactive warm handoffs, but we had to create a new telehealth way to identify and to transition those patients over to behavioral health. So right now we have basically created a central bin where referrals can be made by the primary care provider, the MA, the nurse, whomever, and send a message to our behavioral health team. And those telephone messages are worked every day to coordinate and make sure that somebody outreaches to those patients with behavioral health concerns. Certainly the medical team will, of course, do a suicide assessment for our patients who they're really concerned about, or if they have a high PHQ-9, et cetera. But really, we consider everyone at risk at this point. So for 100% of our patients who we're seeing on telehealth, we are asking them, how are you doing? You know, how has this been going for you? Social distancing, would you like to connect with somebody on the behavioral health team? And I think we've been really surprised that a lot of patients have said, absolutely, I would love to speak to someone on behavioral health. Here are some ideas around how registered nurses can potentially support behavioral health as well. So some of our registered nurses actually were doing some visits specific to psychotropics or antidepressants, things like that. Patients who were started on new medications, instead of waiting 4 to 6 weeks to see the psychiatrist again or to see the primary care provider again, to see the nurse just to check in with the patient. Did you get your medication? How's it going? How are you feeling? Those types of touch points, I don't think we can ever really understand just how meaningful that they are for our patients. And we'll continue to keep their satisfaction high. We'll continue to keep them safe. And really can leverage the unique skill set of a nurse to be able to assess patients on an ongoing basis. There certainly are barriers. So again, direct reimbursement, as I spoke about. You know, most RNs are not prepared to function in the primary care setting. So again, oftentimes you have to give them a significant amount of training. But again, like really making sure that your primary care nurses are practicing to the top of their license, that they really are engaged not only with your chronically ill patients, but you know, doing a lot of health promotion and other things is extremely important. And again, just remember, every organization is at a different place in their transition. So it's going to be very important that you have patience and a little optimism as we go along. I'm gonna, just for a quick moment, and then we'll switch over to questions that I saw one chat come in. What do we need to do to get started in terms of role changes? I think we need to think about leadership, as I had asked you before. We need to make sure that we have champions on our teams that are able to really embrace change and enjoy change and share that with their team members. We need to make sure that we have the policies and procedures and playbooks. Even if they're not in perfect format, just create them. Like, people need something to go to that's written down that will help them to know who's doing what and when. Electronic tools. Even when we did training for telehealth, we actually did one-on-one training with our team. So every provider, every medical assistant together actually met with our training team and walked through a few examples of how to make the breakout rooms for the patients, how to then, as a provider, to move into the room, how to, script the conversation. We had all of that training for them so that they had a lot of practice before they ever did their first telehealth visit. And then, of course, we need optimism and grit, because let me tell you, this is really hard. And I'm sure you all know that. So provider champions are very, very important. And it's important that, particularly as you think about other members of the care team doing different things, it's very important that your providers have buy-in and that they are very supportive of the fact that they have a team surrounding them doing work on their behalf and supporting their patients on their behalf. That of anything will help to spell success. Because again, the teams are going to feel a little tentative. Sometimes they're doing things for the very first time. And again, you don't want that lack of confidence to impact the provider's lack of confidence of, well, then maybe really I don't want this person doing this for my patient. So training is going to be extremely important. And then again, having a provider champion who's excited about the process is going to support their nurse or support their team member to really learn this care and to do it very, very well is going to be critical. Of course, as I said, you're going to encounter those challenges, so you need to make sure that you address that. And as much as you can to create templates or other things to make sure that there is EHR alignment, that there are guides, decision support, and other things available to help people along the way is important. And then, of course, that there's a lifeline, that there's somebody live, a live body that they can link out somewhere, in the healthcare universe. Even my team members, even when I'm working from home, they can link me, they can call me, they can text me if they have a question, because I want to make sure that they have what they need to be successful. And then maintaining the process. I have certainly found that some of my team members who I didn't naturally identify as a leader really have risen to the occasion, and I'm quite impressed with the way that they have, maybe they're the ones who are running their on-site testing teams, maybe they're the nurse who's done the most amount of telehealth, whatever it may be. So those things are very, very important. And then I think for this year, for telehealth, it's going to be critical that you think about your performance appraisal process and that you align the specific goals of the organization and the specific goals for each team member for telehealth. So embracing telehealth. Again, we can't force our patients to embrace telehealth, and they're all going to embrace it to a different degree. So you still have to deliver some care on site, and of course, make sure that you're doing it as successfully and as, using an infection preventionist view. But again, if you can deliver anything by telehealth, you absolutely should do that to preserve your on-site space for the people who really need to be seen on site. So finding out, collecting data, doing patient satisfaction surveys for telehealth, you will find that there will be certain groups of your population that will really, really love and enjoy telehealth. And then there'll be others that maybe really don't. We've even added a flag to our electronic health records so that we know when somebody has had a televisit successfully, so that way we can easily book a telehealth visit because we know that they've done it before. And that way we can better identify patients who need that sort of concierge support right then and there. So I think I'm going to stop sharing right now. And I think we did have one question, Lisa, that had come in on the chat. So what has been CHC's biggest challenge and most effective solution around the workflow for telehealth? I think really our biggest challenge has been adhering to our team-based model of care, but it actually has been our greatest success. So, and part of that is, we're all going to still have to report on the UDS I just muted, sorry. We all are going to have to report all of our data metrics. We're going to have HEDIS. So doing planned care for our patients and keeping our encounters as normal as possible for them, I think really helps them to adapt to telehealth, because I really think our patients have been in 3 different groups: people who love telehealth, people who hate telehealth, and then people who are like on the fence. And if we can tip the people on the fence more towards telehealth, it actually has been more successful for us to be able to meet our visit benchmarks and to be able to deliver this care successfully. And you'd be surprised. I mean, we have people in their 50s, 60s. We even had a 72-year-old who did a video visit the other day. I'm totally impressed. Of course, they had a very engaged family that helped them. But you know, it helped that person to feel safe. They didn't want to come into the health center. So really making sure that you have your ear to the ground, you're talking to your patients, and you're taking their feedback instead of necessarily just assuming that you know. I think there's lots of things that we thought we knew about our patients that we were actually quite surprised. We didn't think that they were going to like video, but some of them really love it. Some of them like telephone so much that they don't even want to bother to go to video. But again, I think we're all a little nervous that the regulations will push people to go to video and away from phone because theoretically video visits are kind of true telemedicine or true telehealth. So that definitely is an issue. Any other questions? You can feel free to unmute yourself.
Yes, everybody, I have allowed y'all to unmute yourself if you have some questions or you just want to make any comments for Mary. Love to hear from some folks. Chime in.
Are any of you utilizing other staff to room? Are you mainly having your telehealth visits be provider only? Looks like Sherry unmuted.
Sherry, can you talk? I'm going to check and see if they're not able to chat for some reason.
Okay. The other thing I was just going to say is that certainly at the bottom of the PowerPoint, you have a copy of my email, or certainly you can reach out to Lisa if there are specific questions that you have specific to telehealth or very specific to your health center. Please feel free to send those to Lisa. I'm happy to answer them and share them and have her share them widely with everyone. Looks like Sarah might have a question.
Not sure why we're not hearing. Sarah, would you like to try again?
Well, it looks like Deb Finley wrote in, and she wrote in, our telehealth visits are mostly provider driven. The nurse is calling the patient first to start the visit, then the provider will do the telehealth visit through our EMR. Oh, and Sherry said she didn't have a question. Yeah, okay. I think to Deborah's comment, I think, you know, that really is sort of a best practice. And again, I think really be thoughtful around like who can do planned care. I think as you think about your team-based model of care, you may want to think about your nurses doing more advanced stuff related to care management, as we'll talk about in the next section that I spend with you guys. You know, and you might find that there may be other staff members that you may want to begin to add to your team that will help you in that rooming process and allow you to save some time for your nurses doing complex care management or other things. But absolutely having a non-provider team member do that planned care is super important.
Any other comments? I'm not sure why folks aren't being able to speak. I've given permission. So anybody want to put anything else in chat? I will read it out.
And certainly, as I said, Lisa, too, if other questions come up that are specific to their health center, please feel free to email them to me. I'm happy to send a written response that you can share with everyone.
Certainly will. Not seeing any other chats come through, but absolutely we will get back with you if there's some other questions. I know how to reach you. I want to thank everybody for joining us today. We really appreciate it. This was some wonderful information. I learned a whole lot myself. And I just want everybody to know you're going to receive another email that actually has a short evaluation. We would really appreciate your feedback. Please continue to go out and register for the other sessions. And I just want to also make a special call out for our session number, I guess it's number 5. It's called Strategies for Optimizing Care Coordination Through Telemedicine. And Ms. Blankson will also be providing that session as well. And that one is on August the 6th. So I hope everybody will be able to join us in as well. We have a comment. This is great. Thanks for all your input. And another comment, really enjoyed the webinar. So thank you for being with us today. And we look forward to your next one on August 6th. Now can you talk?
Yes, now I can unmute. I just wanted to say specifically too, feel free to invite your nursing colleagues. I think the information about care management, I'm going to go into more in depth. I'm probably going to share even just the beginning of one of my standing orders for hypertension or asthma care. It might give you some insight into sort of ways you can utilize nursing even to a greater degree, which will be super beneficial to your providers and to your patients, and obviously bring your nurses a great amount of satisfaction as they use all of the skills that they've learned in school. But really enjoyed being here today. Thank you guys so much for all the hard work you're doing. I know that the bags under your eyes probably look as big as mine have been. I was telling Lisa earlier that they keep getting bigger because since March. So I'm sure I'm sure everybody has been super stressed and working so hard because you care so much about your patient population. So kudos to you for everything that you've been doing. And thank you so much for letting me join you today.
Thank you very much. We really appreciate it. Look forward to August 6th.
Okay, bye everyone.
Thank you. Bye-bye.